You are most welcome to this talk, and particularly a warm welcome to Professor Angus Dalgleish. Professor, welcome back. Thank you for coming.
Thank you.
So Professor Dalgleish is fairly well known to the channel now, Fellow of the Royal College of Physicians in the United Kingdom and Australia, Fellow of the Royal College of Pathologists, Fellow of the Academy of Medical Sciences, and currently Professor of Oncology at St George's Medical School in London, and of course a consultant oncologist, a long-term cancer doctor. So what we want to talk about this morning, Professor, if it's okay with you, is the causes of cancer. First of all, very briefly, what is cancer?
Well, cancer is a disorder of growth and differentiation of cells. Basically, they just escape from their programming. You know, they no longer read the script, as it were, and decide, like escaped prisoners, hey, this is interesting, I can do what I want. And so they start growing or spreading, etc. I mean, that's it in a nutshell. The important bit, though, is that this is a procedure that is expected and heavily regulated. So there are a lot of genes to try and prevent this, which is one of the reasons why cancers take decades in order to manifest them. Having had the first touch of the blue litmus, as it were, it takes a long, long time, and things can accelerate or switch this process off. So that's the first thing I think is really important to be aware.
I was just smiling there because I've never heard the escaped prisoner analogy before, and it really just rang true with everything I know about cancer. We want to get onto that idea shortly, but is it basically true to say that cancers can be described as mutations?
Well, cancers arise as a result of a series of mutations. So you'll get a mutation in a cell, and nothing much will happen to that, except that it is less likely to die in order to do so. This life cycle, cells have the same life cycle as we do. I mean, they're born, they do their job, whatever it is, then they die. And it is having a mutation that delays that dying that allows them to continue for a bit longer. And this increases, just by pure random chance, the chances of a second mutation occurring. And that cancer is often a result of several mutations, at least 6, and in some cancers over 60. So we know a lot of the detail, and I'm not so sure that it enables us to do as much as we'd like to prevent it. However, that's been, in a way, my sort of life's job to understand this with all the various tools at our net to be able to enable. And the one that really got me was viruses. I mean, the fact that viruses can cause cancer, particularly in mice, and that's what really got me very interested in what are the real causes of cancer. And the mice were the ones where they discovered the first mutations, like the RAS oncogene. If you have this mutation in this RAS oncogene, then the cell's much more likely to survive, to get a second hit, and then become cancerous. So that is where we got a lot of our information from. And interesting, a lot of these viruses in mice where we studied cancer are retroviruses. And so I got very interested in this, and this is what I did my MD thesis on. And unlike most people, I did my MD thesis after I'd finished all my clinical training. Normally, you are meant to do some registrar work and then take 2-3 years off and do a thesis. Well, I was offered many, but I never found any of their projects remotely interesting. And so I just carried on doing the clinical, until I got very interested in that viruses were probably causing human cancer as well, but it was just much more subtle. And that's how I got very, very interested in it. And I focused on retroviruses initially, because that's what you did in the laboratory. And the only virus at that time, retrovirus, that was recognized was the human T-cell leukemia lymphoma virus, HTLV1, which had been found to cause leukemia in Japan and also in the Caribbean particularly. So that was what was already known by the time I went in. And then when I started, and this gets really more interesting, is that we were able to work with this virus and see how it caused cancer, as it were. But at the time I moved in, then AIDS had become really big. And it was rumoured that a retrovirus might cause AIDS. And there was a massive search on this. And as we now know, both Montagnier in France and Gallo in America both isolated their own viruses, which turned out to be the same, and they were called HIV at that time. Now, the interesting thing for me as an oncologist at that time was that AIDS was associated with presentations of lymphomas and Kaposi sarcomas, which are both malignancies. So I felt justified my time delving into what was going on with this retrovirus. And just to tell, the conclusion is it's indirect. It's not a direct transformation turning on oncogenes. No, it was indirect by removing the immune surveillance. These lymphomas and Kaposies popped out. They'd had their policemen removed, as it were, and that's so that they felt that able to multiply. They didn't have any of the restraints. But the interesting thing here is what really got me is both the lymphomas and the Kaposies, and it took us decades later before we understood the Kaposies, but both of them were driven by viruses, which are sitting there very well controlled by the immune system. So you can see where I'm coming from with regards how I got interested in how viruses cause cancer, and looking around, there's viruses other than retroviruses. So that's how I got involved very much. And this is how I came across the concept of that cancers arise best in chronic inflammatory states. And the viruses are absolutely a great example of chronic inflammatory states. And if I may say, the first big example on the ward that I came across when I was working in Sydney, as a senior registrar doing medical oncology. And after 2 years, I'd then have the qualifications to be the consultant, which I then became. But I had some very interesting cases. I was particularly interested in the hepatoma. There was a lot of hepatoma in Sydney, and hepatoma means the primary cancer of the liver. So that's it. There was a cancer of the liver, and it would kill people, and there was no good treatment. They're just starting to get some reasonable treatments now, but then it was essentially a death sentence. And I was told, particularly in my training as an internal medicine registrar in general medicine, when we had these cases, I was told that they were due to alcoholism. They were all due to alcohol. And I thought that was a bit odd, because we knew people who had lots to drink, as it were, and never got hepatomas. And then I found, when I was looking at some of the patients, they claimed not to be interested in alcohol or have given it up years ago. So I thought something's not quite true here. And so it'd been reported that by that time, that a herpes virus, a hepatitis virus, hepatitis B it was called, is fascinating because it had a link with Australia. It had an Australian antigen in it because it was found in some indigenous populations. But it was common in Asia, as was the hepatoma. So I got rather irritated that everybody was being taught that this fellow's got hepatoma and it is due to drinking alcohol. And some of these people who have Chinese extract weren't drinking alcohol at all. So at the time, I basically got hold of a very, very early tests for this virus. In fact, it was a pathology collaborator in the Sydney University who was developing a reliable test so they could identify this virus. So I thought, well, what I'll do is I'll get everybody who died of hepatoma, cancer of the liver, in Sydney in the last 2 or 3 years, and we are able to identify them. In their own hospital there was over 40, and so fortunately, because of the interest in this, there was serum from them, so I was able to get stored serum. And all I did was take the serum to the pathologists who developed this test, and some serum from other patients as controls, obviously, and do them so they ran through them blind. And lo and behold, all the hepatomas were hepatitis B positive. I mean, it was really quite remarkable, and all the controls were negative. I wrote that up as one of my first, what I call epidemiology papers. So I started looking at what hepatitis B does. Basically, it causes a hepatitis, acute hepatitis often, which is an acute inflammation of the liver, and it settles down. But then it goes on to cause chronic hepatitis, and then as it goes on to a more consolidating phase, it's called cirrhosis. And it's only when you get that stage that the cancer kind of breaks out. So it's taken all this time. So it's fed by or protected by this environment of chronic inflammation. And this goes on to the point where it escapes. It's interesting, in the cirrhotic phase, there's a lot of angiogenesis there, which gives any cell that's had 1 or 2 mutations more growth factor. It's like watering the rose garden.
So the cirrhotic phase is when there's fibrous tissue in the liver.
Yes, yes.
And the angiogenesis means there's something there in this very fibrous, scarred liver.
Yes.
That's stimulating the production of brand new blood vessels. This angiogenesis.
Yes. I don't fully understand the exact mechanisms, but it's just that's the association that you see from the pathology papers. But only then do you get this, the liver cancer. Now, the other interesting thing was they were occasionally getting liver cancers that were hepatitis B negative. But they were all from people who'd had a history of hepatitis, chronic hepatitis, but they hadn't got hepatitis B. But what they had, and at this time, this was called hepatitis non-A, non-B. You remember that very well?
I remember it well.
Yeah. Well, there's now a few viruses in that group, but the dominant one was hepatitis C. And it did exactly the same. It gave you acute hepatitis, chronic hepatitis after years, and then it too could lead to primary liver cancer. Now, what I was very excited about is these viruses couldn't be more different. Your hepatitis B is a big complex herpes virus with DNA, multiple DNA, and the hepatitis C is a little RNA virus. And yet, completely different, they induce the same thing. So I got very interested in pathogenesis. It was the principle and the story that was required for cancers to evolve. So this was the first insight. It's not confined to a specific virus like hepatitis B. Any virus that induces this inflammation can cause it. So that's when I got really, really interested in the viruses that cause cancer. I think it's worthwhile pointing out at this moment, I had already then realised that there are a lot of other viruses that can cause cancer. And I mean, the next high profile one is human papillomavirus, which in my lifetime I remember reading the papers in Nature saying it was caused by herpes simplex virus. Big complex papers saying absolute proof. And also rejection of people who said it's due to another virus This virus turned out to be the human papillomavirus, which is the cause,
Yeah.
but it wouldn't grow. That was the problem. It wouldn't grow in the culture, so that's why it was thought not to be a real virus, but it was identified with molecular biology and everything in the end. And so that was another example. And that virus actually is very, very important. It causes a chronic inflammation in the mucosa. And that's what leads. You have to have that for quite a long time before you get the cancer develop. The same principle, same story. We now know it's associated with mouth cancers. Over 50% of mouth cancers are driven by human papillomavirus. Esophageal cancers and throat cancers and some lung cancers have this human papillomavirus driving the cancer. So at a stroke, you've got the enormous number of cancers that are common, that we recognize, caused by viruses. So just to recapitulate, I've done the hepatitis ones, hepatitis B, hepatitis C, and I've mentioned the ones associated with HIV, the lymphomas, which we now know is EBV-driven, Epstein-Barr virus, and the Kaposi sarcoma, which is driven by a herpes virus, which again is only discovered relatively recently, HHV6, and they're driving it because they've been released from the immune system. Now, then you have the papillomaviruses. Clearly, this is a mucosal transmission one. So I basically was asked to give a lecture in Leicester when a colleague called Ken O'Byrne was there as a consultant. He's now a professor of oncology in Brisbane, so we kind of switched over. I'd done a lot of training in Brisbane, and he in the UK and Ireland. And I gave this talk up there and saying that after all my HIV work, that I thought that cancers arose in immunosuppressed environments. Well, we knew that from transplants, etc. But that unlike HIV, the immune suppression of the big common cancers, lung, breast, colorectal, etc., prostate, what have you, that the immune suppression is much more subtle. And I said, I think from the model of the viruses, it's due to chronic suppression by the cancer. And the environment they arise in leads to a chronic immune suppression. And afterwards, I'd given this talk. We went for a few beers afterwards, as
you do.
As you do.
Yeah.
And Ken O'Byrne says, "Well, I agree with everything you say, but I don't think it's the immune system's got anything to do with it. It's obviously angiogenesis." He said this is a process where angiogenesis gets to thrive and becomes more and more enabled.
It makes sense because a cancer is a living tissue. So you would need a blood supply, otherwise it would simply go black and necrose.
Yes, absolutely. So this is where, we were basically two scientists examining an elephant. And he reckoned it was, say, the tusk, and I reckon the important part was, say, the ear. And after a couple of pints, or perhaps more, we suddenly realised, I said, Ken, we're describing the same process, but from a slightly different angle. The only thing that causes a chronic immune suppression and stimulates chronic angiogenesis is chronic inflammation. And that is what these viruses are doing in it. And if this is true, then we can look at all the other viruses to see if that fits their pathophysiology, and then that would be it. And you don't need a virus. Well, I'll cut straight to the point. We suddenly realised, you've got lung cancer. That occurs after at least a couple of decades of chronic bronchitis, stimulation, so it has the perfect chronic inflammation and angiogenesis, etc. The other big solid one is colorectal cancer. And colorectal cancer, we already knew, was much more common, 50 times more common, in patients with ulcerative colitis, which by definition is a chronic inflammatory state. But there are patients who don't have ulcerative colitis who get colon cancer. And then we know there's another predisposition, polyps. So I said that polyps, you can have familial polyps or just random polyps. But these polyps, if left to grow, will grow enough, and then enough mutations will occur, then they become cancers. And I asked the pathologist what he would classify polyps as. They have certain things, hereditary, genetic, inflammatory, etc. And he said, oh, without a doubt, they're inflammatory lesions, inflammatory adenomas, but benign. But left to their own devices for 2 or 3 years, they will become malignant, which is why if you have a propensity for these, they screen you and cut them out. If you've got familial polyposis, or even if it's suddenly found you've got a problem and they find you've got polyps, and they go, well, we better keep an eye out in case more pop up, and that's obviously the right thing to do. So we just suddenly realised this, in fact, is what is the big cursor of the majority of cancers. I mean, there's not one theory for everything, but this is not far off it. I think this is over 90% of cancers fit into this. And then Ken, give him his due, he started to research how chronic inflammation affects the oncogene cycle and the suppressor cell cycle. And at this time, we had the NIH had their National Institute of Health in America, National Cancer Institute. They released this progression of cancer cartoon, which basically had, one cell mutates a bit, the next one lives long enough for another mutation. And this was the classic. You needed about 6 to become a cancer and start metastasizing. And we suddenly realized that this was a lovely model just to sink into our chronic inflammation thing, because it was like planting roses into a flower bed. This inflammation was the food and the growth factor. And more importantly, from my point of view of the immune system, is chronic inflammation causes immune suppression and prevents an active immune response from doing its surveillance. And we know T cells can pick up an oncogene that mutates and kill it. But if it's in a chronic inflammatory state, the T cell can't get to it. So the random mutation survives in this chronic inflammatory state. The T cells are suppressed, they're pushed away. And that allows them to go on and get the second mutation. So this explains how you have this scenario where cancers take 2, 3, 4 decades in some cases before they manifest. So the good thing about this is that you've got a long time, you've got a lot of warning time, and from my point of view, it really does say what things can you do to reduce chronic inflammation, because that will reduce your chances of getting cancer dramatically.
Just a geeky point, Professor. If something's inflamed, I would associate that with an influx of white blood cells, like cytotoxic T cells. That's very good and very true. Except you're highlighting that the immune system is quite complex and full of different soldiers, as it were. Yeah. It leads to a big influx of white cells, like neutrophils, for instance, and macrophages, what have you. But the T cells can't get there because this becomes a very inflammatory environment. And we now know that if you do have a lot of neutrophils in your blood with a cancer patient and very few lymphocytes, that's a very bad prognosis. If you can convert that, so you have a healthy T cell and you reduce the number of white cells, then you have a much better prognosis. There's several papers have been reported over the last 2-3 years, just pointing out this fact and saying, I wonder why that is. How does that occur? Because, like you were implying that lots of white cells means a good immune system, means it will control it. No, this is a very good thing. It highlights that the immune system is a delicate balance between T
T cells, the frontline warriors, your front line of the army, as it were. And when they encounter a foreign invader, like COVID, for instance, they charge up and they beat it up, and they send signals to the B cells, which take a while to kick in, especially for a new one, and then they make antibodies. And then your program memory cells, so when you meet it next time, you should make the antibodies very quickly. They program that. But what we find is this natural balance is disturbed. And when we wrote these papers, we've done many papers and books and chapters on this, is when you have the chronic inflammation, this balance is completely disturbed. So the T cells are completely suppressed. And we found out it was no different in patients with TB, HIV, and cancer. It's a remarkable similarity, and therefore a potential, can you use something to restore those T cells, and would it work and help in HIV, TB, and cancer? Well, of course, that is where we realized that there was something that did that, and that was these mycobacteria that were being used for TB. They were then shown in HIV patients to reduce their chances of getting TB. Big papers published in what then was a useful, reliable journal, The Lancet, which I don't believe in anything published there now, because it seems to be a purely political journal.
It used to be the absolute gold standard in the old days, wasn't it?
Absolutely. It's been totally perturbated. I think it is tragic and a disgrace. And so that's basically what put it together. And then out of that, you know, I must give credit to Graham Rooke and John Stanford. John Stanford sadly has passed away now. But they realised that BCG made a difference. But there was a problem. There was a problem with it, and they wanted to make it better. And it's a story in its own right. But they discovered Mycobacterium vaccae was the core to getting a good, reliable immune response in TB, patients exposed to TB, and patients with HIV to stop them getting TB. And when I looked at this, what they were doing, I took a great interest in this concept. I realized this funny heat-killed organism was able to reverse the seesaw. It was able to boost the T cells and, more importantly, suppress the over-enthusiastic and actually dangerous chronic inflammatory responses of neutrophils and macrophages. And that's exactly what it does. And then I said, well, this is exactly what's going on in cancer, courtesy of my big interaction with Ken O'Byrne. Anything that boosts the T cell response and dampens down the inflammation can only be a good thing. So that's how I ended up getting hold of the M. vaccae, and in the days before the European Union Clinical Trial Directive, which is a mechanism to stop innovative, creative and useful studies by academics such as myself.
This is when you were allowed to be a doctor.
When you were allowed to be a doctor. I basically said I want to do a trial on this in my patients. We don't have any, at that time we had nothing, and they would go for anything. And I was very happy to try anything, providing it wasn't not toxic. At the time, we were allowed to give them interferon, which I was only in the clinic for a few months, and I said, this drug's ridiculous. And remember, it had been approved. It had been approved. I said, I'm not impressed by any benefit, but I am impressed by the side effects. They're just unacceptable, particularly for patients with low-volume disease. So I switched to the studies with M. vaccae, and it was no time at all you could see that there was great benefits, much better than interferon, using this. And that trial, I was able to write, dear sirs, I've got this stuff, I'd like to try it in the cancer patients. It's been given to thousands of people with HIV and TB, so there's no problem there, this, that and the other. And then at the end of the month, the chairman of the ethics committee said, we don't see any problems with it, off you go. I say that because anybody will laugh at this, knowing if you want to do a trial now, you're looking 6 months a year to get started, unless you got big pharma behind you who suddenly decide that they want to get this out as soon as possible. Then all these obstacles seem to disappear, as we found with COVID vaccines and things like that.
Absolutely, yeah. And if this Mycobacterium vaccae vaccine was available, I would have it, because I think if it boosts my T cell response, it's going to reduce the probability of cancers developing.
Well, exactly. And as I said at the time, and I offered it to Whitty, that we did actually have enough of the vaccine to do every frontline hospital staff in the COVID crisis. And they turned it down as not enough evidence. Can you believe it? That means not enough understanding or common sense on the grounds of the people who should know better.
So it's a pity, because not only would have these people have been protected from viral and bacterial infections by the upregulation of the T cell response, we'd also potentially have a massive reduction in cancers in all health service employees over the next 10, 20, 30 years.
Well, I mean, that's a ludicrous solution to jump to, if I may say so. But
it's one that should be tested.
But I suspect you are right. Do you know why I suspect you are right? Because I've tried to keep busy, as you know, and I've been to all sorts of immunology meetings, virus meetings, and cancer treatment things. And one of the little groups I was in, which is basically a sort of clinical immunology and diseases in humans that are difficult. One of the things that staggered me, because I became a great fan of BCG, which is why I got it, but you can't use BCG more than a couple of times, otherwise you get a negative response.
This is the standard vaccine against tuberculosis.
Yeah, exactly. So I got very interested in that, and I realised that you needed a stimulation you gave repeatedly, and that BCG doesn't do that. So that's why we got into these heat-killed ones, which do. So just explaining that bit. But the reason I suspect you're completely right was that at one of these meetings, I think it was one we had in Cambridge, there used to be as a nice place where we could chat and go to the local pub as usual, that sort of thing, and chat over it. And one of the things that they had found in long-term follow-up for BCG done in Africa was the guy presented, because they were able to do long-term follow-up, which you can't do in most grants these days because they're 5 years or something. So what they found and what they presented, they said, we've got some data here and it's real and we really didn't believe it and we can't understand it. It said, but in our cohorts of children given BCG in Africa, we've compared them to children in those countries where they wouldn't let us give BCG. I mean, there are such things. And it said, it's amazing. It said, the people who got the BCG as children, 50 years later, they have lower incidence of heart attacks and cancer. Wow. So that means at that early stage, their immune systems were set like this seesaw with the T cells a bit damped down, but it had corrected it. And that equilibrium was enough for them to come across all sorts of things the rest of their life and have a lower incidence of heart disease and cancer. So that's why I said your statement was ludicrous, because I mean that's what I'd say to myself, because I make those things. I said, but here, to my amazement, I must say it is the one paper at that conference I remember. I don't even remember my own paper.
I can make plenty of ludicrous statements, but it's nice to nice to have it be discussed by someone who, with your experience.
But I think you're absolutely right. But we can't make claims for products you have an invested interest in, because they won't allow you.
Yeah. Because
I've always played with the idea you have a new drug, a thing you could call it like Curamycin or Wandacillin. You're not allowed to do that because it implies untested efficacy. So that's why I'm saying that.
Yeah. I think I'm starting to understand that cellular imbalance now, because if you've got chronic inflammation, presumably that's going to alter the cytokine profile of the local area of tissue. And cytokines are actually specific to particular immune cell types. So it's not... I think it's important actually to relate these things back, because this does make sense in terms of basic science.
It does.
So what you're discussing has got complete scientific credibility, as well as provisional, pretty convincing empirical evidence. And it just seems tragic that this isn't being followed up, especially when the risk-benefit analysis is so positive.
Exactly.
Because what the heck is the risk of giving a few heat-attenuated Mycobacteria vaccae into my arm? I can see pretty well no risk from that, and yet the upsides are potentially immense.
No, as you say, there are no risks, and there haven't been any risks in all these studies because it is heat inactivated.
Yeah.
And
you're giving a precise known dose. It's not like one of these RNA viruses where you could produce 6 viral particles or 6 trillion viral particles.
No, I mean, it's totally safe because it's heat killed. It can never be resurrected to life like RNA or BCG. See, BCG is attenuated. It's his life. Yeah. And I have dealt with 2 patients over my time who were on BCG in trials we did in collaboration with the Donald Morton, the John Wayne Institute. A lot of the vaccines had BCG as the adjuvant. Occasionally they can cause lymph nodes, and you find these patients have got a very low level of TB. Fortunately, it's very easy to kill because it's attenuated. You can just do it with a short course of rifamycin. You know, it's very easy. But less than 1%. You know, but it's still there. So the fact we don't have to worry about that whatsoever, it gives us, you know, confidence that we're not going to do any harm with this.
Well, one of my early memories about working with cancer patients as a young staff nurse is so many women coming in with advanced cancers, pathological fractures, horrible things after cervical cancer, and that's another human papilloma virus.
Yes, very
chronic
much
inflammation.
So.
Yeah. The term retrovirus, can you just unpack that a little bit? What's the difference between a virus and a retrovirus?
Well, a retrovirus is a virus, first of all.
Yeah.
So it's a subclassification.
Subclass, yeah.
It's a subclassification. Most viruses that we have associated with cancer in humans have been herpes virus, like the hepatitis B virus, like the Epstein-Barr virus, for instance. I mean, they're the big ones, and the Kappa C.
These are the big DNA viruses.
Big DNA. Now, DNA makes RNA, which makes protein, which makes money, as one of the as one of the people in the Cambridge molecular laboratory of molecular biology in Cambridge said. I can't remember which one that was.
Sad but true.
I think it was Sanger or Perutz, these big guys who were there. But always remember them saying that because they were predicting the biotech revolution. So your DNA makes RNA, makes protein, but a retrovirus is an RNA virus that codes the other way. So it goes into DNA and recodes that to produce whatever it does and make its proteins to replicate, etc. And in that little definition that I've just told you, I think I've just told you why I believe messenger RNA viruses are so dangerous. Completely, utterly dangerous, and why I've been campaigning for them to be banned. And, you know, I'm used to all sorts of insults, and I know that I was told I'm just a cancer doctor, what do I know about viruses, etc., all this. But I have been... Well,
you're just the most senior oncologist in the country, but we'll pass that point over,
But I wouldn't necessarily say that, but I have been on many scientific boards of companies developing vaccines, and, you know, gone into it great depth. And I have been on the board of a company that purely focused on making messenger RNA vaccines. So, I mean, I was on the board for 5 years. I did my cycle. And I got to know that there was a big problem. And that big problem, I left that board 7 years ago, and I now know that problem's still not been sorted. And that this pandemic was used as an excuse to get round all the problems that the regulatory people wouldn't let them go through before. That's a terrible thing. But that explains what a retrovirus is. It is actually an RNA virus that can go into the DNA and reprogram it. And in mice, and we know they've only got one human virus that does that, HTLV1. They reprogram it, and you get cancer. So it's a big risk.
Well, congratulations on leaving that when you did. Now, this DNA makes RNA makes protein is what we call the central dogma, isn't it, of genetics? You know, every student learns that DNA makes RNA makes protein. But we clearly know that these retroviruses, RNA makes DNA. It goes the other way round. Then, of course, that DNA can make more RNA, which makes more makes more protein. Now, in order to get RNA to go to DNA, we need an enzyme called reverse transcriptase.
That's right, yeah.
So transcription is the DNA to the RNA. The reverse transcription is the RNA to the DNA.
Yes.
Now, that reverse transcriptase enzyme, which is essential, is that produced as an endogenous product of human cells, or is that always coded for by RNA that comes in with the virus?
Where the virus is involved, it encodes it itself. It has its own reverse transcriptase thing.
So the RNA in the virus itself codes for its own reverse transcriptase.
And that is what provided the first target for treating HIV. They used reverse transcriptase inhibitors, so it wouldn't be able to integrate and have the life cycle. That yeah.
Yeah, it's a bit of an unfair question, really, but is there endogenous reverse transcriptase? Do human cells produce reverse transcriptase, or do we know that?
I will be very honest here. I'm not sure, and so I'm speculating, but we do have endogenous retroviruses, a large number of them in the genome.
That accumulated over millions of years of evolution.
Accumulated over millions of years of evolution. And they can escape, as it were, and we think that other viruses help these escape, because this is the pathogenesis of multiple sclerosis. There's a lot of work out there to suggest that these sleeping dormant retroviruses, which are just part of our genetic baggage that we come with, about 90% of our genome is so-called baggage. And that's another fascinating thing, is why do we carry it around? And just for the viewers, the simplest solution is, I think it is, if you imagine you pass all your genes on all the time, and they're just a big baggage of genes, how are you going to make maximum use of it? Whereas I think that 90% of baggage is the equivalent of a library's shelving and retrieval. So it allows you to put the useful genes in an order and assembly. You can retrieve them when you need them and want them. I mean, it's not been proven, but that's a speculation which I feel most comfortable when discussing these. So what happens with the so-called multiple sclerosis is that another virus comes in and helps provide a reverse transcriptase that virus does not have, and enables it to wake up and start sleeping. Multiple sclerosis, we still don't know exactly what's going on, but I think that's the closest model to it. And there's other complications in that it's very genetically restricted, and it's clearly got an autoimmune component to it. So that's. I just wanted to answer your question, but I don't want to get into multiple sclerosis.
No. I would love to, because it's. We'll try and stick to the topic. So I think basically what we're saying is we have this idea that we're in a milieu of viruses. Epstein-Barr virus, for example. I assume we've all been exposed to that.
Exactly.
And we live with all these viruses. Most of the time they're kept down by an active immune system. Chronic inflammation comes along, messes up with this cellular differential. We get more of these neutrophils. Neutrophils, of course, are brilliant if you've got a bacterial infection. It's exactly what you want.
Exactly.
But it's not what you want if you've got chronic inflammation. Suppresses the T cells, and it's this chronic inflammation that leads to the development of cancers. And that kind of combines the initiator and promoter model of cancer, really, doesn't it?
It does. And can I just add an extra piece of information
Please.
I forgot to show that the chronic inflammation causing cancer is a reality, and that interfering with this is a reality, is that the experiment has already been done. Rather like the BCG and TB, looking beyond that, how it actually reduced cancer and heart attacks 50 years later. Remember, they did big studies looking at the effect of aspirin. Now, aspirin is an anti-inflammatory agent which blocks COX-2 pathways, and it also blocks prostaglandins, and therefore propensity to clotting. And
in other words, it reduces the production of inflammatory mediators.
So we know that it made a difference for heart, but once again, those big studies also gave a signal that the people on the aspirin had a lower incidence of colon cancer. And so that's a perfect example of serendipity. You set the study out to do one thing, but if you broaden it and look and ask other questions, and it showed that anti-inflammatories would reduce the incidence of colon cancer, and aspirin was ideal. Unfortunately, aspirin is very cheap and easy to get and take. It has the problem that if you take it as a tablet and you don't take it with meals, it can give you gastric problems and bleeding. And occasionally, very occasionally, the bleeding can be fatal. And the problem is that a GP only needs to have one or two of these in his life, and he gets very wary about advising aspirin at all. But that is to forget that aspirin, you can have it in a low dose for the clotting, at 75. But you need higher than that for its anti-inflammatory. But I've always advised that if you take the anti-inflammatory soluble with a meal, it greatly reduces. And I do that myself. I mean, that's the way. I would not have an aspirin in the middle of the day for a headache, because that'd be guaranteed problems. If I need a headache, and sometimes sinusitis, it is the best treatment for a chronic sinusitis, I just pop the soluble in, and I take it, and if it's urgent in the middle of the day, then I'll take a yogurt with it. It's something to protect the stomach. So all these, sort of sensible, logical things to do can work through. But at the end of the day, I mean, I'm a great believer in daily anti-inflammatory tablets for everybody over 40 to reduce these pathways. I mean, you might be targeting the one for colorectal, but it's probably preventing others. But it looks like it has a benefit on lung cancer as well. But there's plenty of other anti-inflammatories which can be looked at and for prevention. Now, the other causes of chronic inflammation, I mean, smoking is obvious. So I'm not going to waste any time on that. And that cause, I mean, most people who present with lung cancer have a history of chronic inflammatory upper respiratory diseases every winter, chronic bronchitis, etc. They get admitted to hospital, and eventually they're found to have the cancer. That's a fairly logical one.
I mean, it's obvious smoking is going to contribute to the chronic inflammation, isn't it?
It is. It absolutely is.
But is the tyra-direct carcinogen as well? Is it kind of a double whammy?
It's double whammy. I'm absolutely sure it's a double whammy. In fact, there's so many carcinogens in smoke, we don't know which one is doing it. It's just, you just increase your risk. It's as simple as that. But what I wanted to get onto, there is another cause of chronic inflammation, which is driving up cancer of all sorts. Initially, the signal was for renal cancer. People wonder, what on earth causes renal cancer? And then it was womb cancer, uterine cancer, endometrial cancer. What on earth causes these? And this is, I think, is the most fascinating link ever. The link is with obesity. Now, obesity, if you have to describe it, put it in a pathologist's pot, as it were. They only have a few pots, but everything has to squeeze into one of them. Obesity squeezes into chronic inflammatory state.
Yes.
If you are obese, you have far more cells than the thin person next to you. And therefore, they need feeding, and they need turning over, and they produce their own inflammatory growth factors etc. And so obesity is a chronic inflammatory state. So probably the very best way we could reduce cancers in this country would be to prevent obesity and do everything that's required for it to reduce it, because it is associated where you're much more likely to have all the cancers,
pretty well all of them, all the
yes,
common ones,
all the common ones.
Yeah.
So that and to me this is really like reaching the peak of the mountain of this, because it is so overwhelmingly explains why these people have more cancers. A couple of very simple things. First of all, because they're really obese and big, they've got a lot more cells. And then when you've got a lot more cells, you've got a lot more opportunity that one of those might go malignant, just on a random alone. Let alone the fact that the more there are, like, people in a room, they huddle up, the warmer they get. And that sort of warmness is an inflammatory state, producing more warmness, more growth factors, more immune suppression. So that's...
I wasn't aware of that. That's interesting. I assumed that in obesity the adipocyte number this fat cell number was fairly constant, and they just kind of swelled up and got bigger and bigger. But there's actually an increase in the number of the cells present.
Well, that's a very, very good technical point.
Sorry,
and I'm not qualified to answer that. I'd actually want to research that. But let's move to a paradigm. It is certainly true that bigger people, genetically, without being obese, are more likely to get cancer because they've got more likely to they've got more cells.
They've got more cells, yeah.
For the random mutation.
Yeah.
And we know that that's the case in dogs too. The bigger dogs much more likely to get cancer than the smaller dogs.
Interesting. So my thinking here would be then that the amount of fat, whether it's more fat cells or whether it's full fat cells, that's going to cause an abnormality in the function of the cell that causes these cells to release inflammatory mediators systemically. Is that kind of what's going on?
Well, it must be, right, because why, if you eat too much, do you get fat? And as you say, these cells go into adipose tissue, and they are there to deal with excess fuel, to store it in times of when there is none, as it were. And that's one of the reasons why people in the Pacific, Indonesian islands, why they're so big, and the Maoris, because they adapted. In good times they got big, because they'd have to sail the oceans for several days without any food at all, and that extra capacity allowed them to do that. The problem is with obesity, there's no downside. So they keep going on, storing, and that interferes with all the metabolic pathways. Diabetes is one of the obvious, very common
vascular disease and everything that can go with that.
Yeah.
Right. So this is so interesting. So all the common cancers, so lung, bowel, prostate, breast, pancreas, esophagus, liver, bladder. Obesity is a potential factor, maybe to varying degrees of etiology, but a potential factor in all of these really common cancers.
Yes. And of course, in two of those, breast and prostate, you have a hormonal aspect as well. But then the hormonal aspect can be affected, by chronic inflammation and immune status. So that's very complex. I mean, I think the breast and prostate are more complex because of the hormonal aspect. But to me, prostate is more understandable than breast. I think breast is much more complex with regards to the real cause of inflammation. Obviously, hormone has a lot to do with it. But males get breast cancer too. Obviously, not nearly as common, but it shows that the hormonal aspect just makes it much more likely. But the other aspects can also be affecting these tumours as well.
I tend to think of the male breast as being like a prepubescent female breast in a way. There's still like a basic ductal system there that can be stimulated. And of course, men do get breast cancer. It's Physical activity, is that... I mean, it's good, obviously, but in terms of cancer, is it protective, do you think?
I don't think I know. And
that's a very revealing answer, actually.
Yeah, but they're very detailed results in mice where they're all identical. They're all given the same stimulating factors to develop cancer. They're known to get cancer eventually, so you know. So it's a very good model for what you can do to reduce the cancers. So they've done, and this has been repeated many times. You'd have mice which are just walk around the cage, and then there's mice that have the opportunity to run in a wheel for a certain amount of time a day, and this is all monitored. So the ones that have a lot of exercise develop tumours far slower than those that don't do a lot of exercise. And I'm sure, unlike quite a few things where the mice doesn't quite translate the human condition, I'm sure this is very relevant.
Mm-hmm. Mm-hmm. I mean, it's good to be physically fit anyway, yeah. So it's generally. Just run, if you don't mind, just a few minutes to run through some of the common causes that that I used to teach my students about. Certainly, sun and ultraviolet radiation.
Yes.
Just skin cancers or anything else could be involved in that?
Well, that's inducing a chronic inflammatory state in the skin. And when I was trying to work out, what was going on with melanoma, I said, what's causing this? And I actually at a conference actually said there's a great irony that all the cancers seem to be involved with chronic inflammation except the one that I've been given to treat, melanoma. And actually pathologist came to me afterwards and said it's no different. He said, I can tell melanoma patients just looking at their normal skin, because they don't have normal skin. They have a sort of chronic inflammatory fibrous skin. And he also said that is one of the reasons for your other big quest, is why do so many melanoma patients have such low vitamin D levels? And he said is the skin is become inflammatory and no longer does that vital conversion for the sunshine vitamin, as it were, as we know from the title of one of David Grimes' books. Yeah. And so that is why. So even the melanoma it is a chronic inflammatory state which it leads to a propensity for the melanoma.
Wow, that really fits in well. And vitamin D, of course, which we know, I think I'm safe in saying that we know low vitamin D levels are involved in the etiology of many cancers. And that is, vitamin D is an it activates many genes and controls genetic expression, but it's also anti-inflammatory, isn't it?
Yes, it is very anti-inflammatory. I mean, it's absolutely vital for the immune system, and it's actually vital for the inflammation. I remember when I was doing really hard research on this, and I found that a very good papers in immunology, you do not have an adequate level of vitamin D, then your activated CD8 cell, it will latch on to an antigen on a tumour cell, and it will just sort of kiss it and go away.
So the CD8 is the T helper cell, isn't it?
No, the T killer cell. The activate T killer cell.
Oh, sorry, yeah, it's a CD. Yeah, I always get CD4 and CD8 mixed up. That's CD8 is the killer cell. Sorry, the cytotoxic cell.
Yeah, and the CD4 is the helper cell that gives it all the signals.
That's it. Yeah.
So the CD8 won't kill that tumour cell unless there's a healthy level of vitamin D. So vitamin D is actually required for the T cells to do their job. And then I found another paper that says that there's over excessive antigen production in low levels of vitamin D. Well, this appears to be a paradox initially. But no, when you look at it very carefully, it's dendritic cells presenting the primary antigens to the immune system to program it. And if it's low vitamin D, it's not very good at presenting just the necessary ones. It gets sloppy. And this leads to autoimmune disease. Nice. And so this is why autoimmune disease is associated with low vitamin D. And most people working in autoimmune diseases, now one of the first things they do is pick up on low vitamin D and treat it. And one of the first, well, this was recognised, was multiple sclerosis. And multiple sclerosis, the first thing you do is correct their low vitamin D levels. And that's the start on the path to treatment and being able to help them, because it is basically an autoimmune disease attacking your own myelin.
Mm-hmm. Yep. Different radiations as a cause of cancer. I mean, X-rays, for example, X-ray exposure, or I mean, what would be the mechanism there? Can the radiation physically damage the genetic material? That's what I always taught.
Oh yeah, and it's right.
Yeah.
And it's a matter of dose and time.
Mm.
I mean, that's why we can safely use X-rays, because we know the dose is very, very low, and also why that we get worried about people who need X-rays frequently for long periods of time, and we go out of our way, like people who have need a lot of CT scans, for instance. They're now much lower radiation, but we'd switch to the MRI, which doesn't do that. So we've got an alternative, or echo. I mean, a lot of tumours and things can be done with very, very sophisticated echoes.
And that gives another cause of cancer, which is iatrogenesis, caused by medical treatment. And
it's fortunately quite rare now. So yeah, I think it is very rare. In fact, the things that come to mind are more radiotherapy causing other diseases later in life, like heart problems and people who had their chest irradiated for Hodgkin's when they were very young. But once again, we no longer give too high a dose, and two, we're much better at focusing it and avoiding structures that might be damaged by it.
Yeah, that's good. And of course, in the iatrogenic category, you already mentioned there people that have had transplants and need chronic drugs to suppress the natural body's natural repression. Is it true that they are more prone to certain cancers?
Yes, certainly.
After years of immunosuppression?
Absolutely, especially skin cancers. Very interesting, of all sorts.
Yep. Shall we recommend people to have a good diet and avoid junk food?
Well, obviously, and this links in with obesity, because obesity is associated mainly with junk food. I mean, I've done my own observations that what do fat people eat, and they have a terrible diet.
Yeah.
I mean, and
this is a common observation. We see this repeatedly, don't we? I mean,
yeah. And the other thing, they seem to be eating all the time, even while driving.
Yeah.
I mean, I'm quite impressed. Now, so a good healthy diet is important, not only to avoid being overweight, but you need a high fibre diet in order to have a good microbiome in the gut, which basically means you have a good, healthy immune system. So the diet even helps program your immune response and your immune system. And of course, in the absence of the right amount of sun and everything, a major part of that is vitamin D. Vitamin D, and that is a fat-soluble vitamin. Well, actually, as David Grimes has pointed out, the tragedy of vitamin D was it was found after vitamin C, i.e. it's not a vitamin, it's far more important than a vitamin.
No, I agree with that. And we've just done an excellent recording with Dr. Grimes, which will be available. Yeah,
I can't wait to hear it, actually, because I know...
Oh, it's up there. It's
I'm a great fan of his.
Good, it's great. And we went to the pub after for a couple of beers, so it was a really good day. Various minerals. I mean, I'm thinking about Japan, South Korea, where they eat lots of seaweed, high amounts of iodine. I'm thinking about the UK, much higher rates of breast cancer, where basically we don't eat seafood. Do you think there could be anything in things like iodine, being replete in iodine and other minerals?
Yes, I do. It's not an area I've researched in depth, but I have engaged with others who are convinced in the same way that I'm absolutely a talisman for vitamin D in cancer. The next thing that you get these people who've done a lot of research in is, funnily enough, iodine. They talk about Lugol's iodine being most important because of its deficiency. So, yes, there'll be many others that we don't know about. But
I take a drop of iodine a couple of times a week now. I think it's a milligram or two.
Right.
You get used to the taste. Because I mean, I was working out, you know, if you eat kelp, for example, you're getting huge amounts of iodine, and we get nothing like that amount. And of course, it's homeostatically regulated, so within reason, you know, if you take more than the body needs, it will simply be excreted in the urine. So
yeah, and you remind me that you live closer to Derbyshire than I do.
I do, yeah. And of course, the reason you're saying that is Derbyshire neck,
exactly,
or Switzerland neck, or Nepal neck, where the thyroid swelled up through simple lack of iodine.
Exactly.
But of course, the other thing that's fascinating is this idea of the amounts, the levels of things like vitamin D and iodine were set to prevent. The amount of vitamin D was calculated on the amount to prevent rickets, which of course is an extreme form of bendy bone disease. The amount of iodine was set to prevent goiter, which is a sign of really quite extreme iodine deficiency. There's a difference between the amount of substance needed to prevent a particular deficiency syndrome and an optimum level. And I think that's what a lot of these blood levels and dietary recommendations haven't quite come up to date with yet.
Well, neither have the so-called experts. I mean, there's a special advisory committee, like it's a sub-one of SAGE, which is one of the most inappropriate acronyms ever invented. Anything but SAGE, they should call it. But the other one is the Special Advisory Committee on Nutrition, who are full of such dimwits that they feel that 400 international units is the maximum that should be given to the British population.
Yeah.
And I've challenged them, and Whitty agrees with them. I mean, it's
tiny amounts of vitamin D.
Yeah, that's a good thing that you mentioned. That is probably what you need for rickets, because it's the extreme.
Yeah.
But for good health, you need far more than that. You need at least 2-3 times that. I mean, the minimum supplementation should be 1,000 international units. And in the winter, in the north, the minimum is 2,000.
Yeah, and I mean, if you think about it, so we've got the government recommending 400 units. But if you go out on a sunny afternoon with just your shorts on, you're going to make 20,000 units. The difference is just incredible. Can I keep drinking some lager on Friday nights?
Well, I think it's terribly important to have some alcohol if you're used to it. And,
I'm afraid so, yeah.
And I think that suddenly becoming righteous and stopping it, in my observations, doesn't seem to be a very good thing to do. I don't know why, but I mean, a moderate amount of alcohol is full of things. I mean, beer stimulates your pious patches.
Yeah, the yeast in real ale, I think.
The yeast in real ale, particularly. So that's the justification for my beer. Now,
if you're watching this video and you don't drink, please do not start based on this conversation. But I mean, it's true. It's huge amounts of alcohol, though. Chronic inflammation.
Well, that's right. Huge amounts of chronic inflammation. But the other thing about red wine, the active ingredient in that, apart from alcohol, is resveratrol, which is a very powerful anti-inflammatory. So, you know, things in moderation are fine. Everything in excess. I mean, the moderation is the thing, isn't it? It's food. If you don't eat food, you starve. If you eat too much, you're obese. So you need something in between.
And very often in physiology, we don't have a linear relationship between two variables like alcohol and cancer. It's very often an S-shaped curve, isn't it? So it's low at the bottom, essentially no risk. Then it goes up sharply.
Exactly.
When you get to a particular critical dose, physiology often follows this sigmoid curve. Just workplace cancers. I mean, asbestos, for example. I mean, that's a clear risk, isn't it?
Yes. And it's very interesting, asbestos, because I worked at the time, I was involved with the MRC, that they came out, this has nothing to do with me, I was working independently, but they came out and they did these big surveys, because they did, you know, the one on lung, Richard Dolan and etc. and Pito did the big survey showing that smoking clearly caused lung cancer, which the industry fought against for years and years and years, so that it was super obvious to everybody. Well, there was asbestos and mesothelioma. And that link was there for a long time, and they monitored it for about 20 years. And I remember they came out and said there was no link. After
I mean,
20.
I think Richard Doll knew about this in about
Yeah.
1960, I think.
I'm sure he would. There's no link. And so that became an official report. But thereafter, the link became stronger and stronger and stronger. And
It's only when it became absolutely, totally obvious that the link was admitted. It's just ridiculous.
It was. And the interesting thing about asbestosis and mesothelioma, the average is at least 40 years. 40 years exposure. And what is the exposure? It is bits of the asbestos that get ingested and they can't get rid of it. They're indigestible, quite literally. And that gives rise to a very low chronic level of inflammation. So mesothelioma rises out of a mesotheliitis, basically, due to the macrophages and fibrocytes having real problems trying to dispose of these particles.
And mesothelioma is a totally hideous disease, isn't it? Pleural membranes.
Yes.
Swells up, occupies virtually the whole space, squashes the lung. Terrible.
It is.
Terrible disease.
And I must say, I applied those principles to treatment, and I have treated patients with mesothelioma with IMM when I could get it for anybody. I can't at the moment because it's going for registration trials, but I was able to do that. And
so the IMM is one of these mycobacteria vacci vaccines.
It's the one that we're focusing on now. And maximising anti-inflammatories, which in these cases that mean included vitamin D, because vitamin D is a very strong anti-inflammatory. And I've had amazing stabilisations with that.
Wow.
In patients who refuse chemotherapy. Because they look at the chemotherapy,
horrible,
and the surgery and the radiotherapy, and it's been staggering. So once again, it proves that an anti-inflammatory, and people will say you can't possibly say that on a few patients. Well, I can say that on a few patients because that is what years of being a doctor dealing with all these things. You're very good at sniffing out what's effective and what's not, and they only say you can say it when it's been shown in a randomized trial. Well, I have no longer got any big faith in randomized trials, and I've got people who agree with me. Ever since when we published the book of the Death of Science, I've had people contact me saying that they basically want to look at writing papers and doing a thing on that should be the death of the death of the thank you. The death of the
it is excellent.
The death of the randomized trial, because now we know that the randomized trials for COVID were completely perverted. They weren't randomized at all.
I mean, there's nothing wrong with the principle of a randomized controlled trial. That's a great scientific principle. You know that goes way back to the discovery of streptomycin for tuberculosis. That's great, but it's the way it's now applied in practice, and he who pays the fiddler calls the results of the clinical trial.
Yes.
Yeah. Briefly, we're nearly finished. Air pollution, microparticulates, are they a risk?
Yes, clearly.
So things from smoke, incineration, diesel fumes.
Here I have a little cough there. But from time to time, it's not COVID, it's none of these things. I call it diesel lung. And that's, after years of being exposed to lorries shooing out these particles, it does make...
Which are tiny particles.
And it does make you cough. I mean, it's possibly worse than smoke. But, I mean, we go over the top now. We want all these things to be electric, but actually the new diesel engines are really very, very clean.
Yeah. As long as the filters are working.
As long as the filters are working right, yes.
Yeah, but you're right. We've been exposed, unfortunately, in our generation to many decades of abuse. Is radon gas a problem globally, or is that just a UK thing in very small pockets of the UK?
I haven't looked at this in detail. I'm not an expert in it, but my understanding is exactly your last bit, that it's a problem in small pockets in the UK where there's very high levels, and it's been linked with lung cancer.
Yeah, I think Alston near me was known. You have to test the cellars to see if it accumulates there. And cancer, of course, gets more common with age. One thing I've never understood, why are occasional cancers more common in young people? So, for example, you think of testicular cancer, more common in young men, whereas the vast majority of cancers are more common with age.
Yes, they are.
Why is there a difference there?
Again, testicular cancer, I don't think is associated. I mean, there's exceptions to the general broad hypothesis of everything.
Of course.
Yes. So I think that testicular definitely does fall outside that. The good thing about testicular cancer in young men is it's completely curable if you catch it very early. It's incredibly curable. But thank you for giving me that lead, because it reminds me to make it very, very clear to everybody that your major risk of cancer that you can't control are your genes you inherit from your parents.
Yes.
And they're so genetic. So just because you get a cancer, and this is true, you get lung cancer in people who've never smoked, you get early cancer in all sorts of things, but they've never been subject to chronic inflammation. But we've known much more about that. It's more in the textbooks. You get these genetic conditions which make you much more likely to develop cancers, and that you've inherited those. And I mean, the one that springs to mind is the BRCA mutations for breast and ovarian.
BRCA, breast cancer.
Yeah, exactly.
Yeah. And of course, if we understand these causes, we can take steps to prevent it, which is the entire point of this study. You know, I think that stuff is absolute gold dust. I was just fascinated. That's an hour and 15 minutes. I was just riveted all the way through, really. It's really good to get confirmation of some of the things I've taught over the last 30 years that they are actually correct, because you know, talking to a specialist is really reassuring in that respect. Professor Dalgleish, as always, thank you so much for your time and giving us the benefit of your entire medical career, all canned down into one video. Absolutely amazing. Not that we've done it any kind of justice, of course, but
some of the things I've just touched over 30 seconds, when in fact I could go on for hours and hours and hours in depth on many of those things. So I'm just giving you the broad brush.
Well, if you want to send a list, I would be delighted. It's many more things we can do, but for now, thank you so much.
Thank you for asking me. Thank you.